Hello, everyone. Welcome to the University of Michigan's CF Family Education Night. While this year might look a little different, we hope you still find the information just as valuable and maybe a little easier to attend even. Before I go too far into introductions, as you heard a second ago, this call is being recorded. My name is Marielle Boza, and I am a Senior Development Director at the Michigan chapter of the CF Foundation. I am honored to be the first to welcome you tonight, along with the rest of our chapter team. Shelley Francis, Abby Stappa, Haley Malloy, Valerie Phelps, Ariane Scherer, and Carrie McLaughlin, who is running tech tonight. Plus a special thank you to Eddie Fields from our Bethesda IT department for giving us a hand tonight. Over the past few months, we've had the privilege to work with the U of N Center during the pandemic by combining our technology and the center's information for various updates, while everyone has been at home. Everyone in our chapter misses you all so dearly, but know we're still here for you, and we're still working very hard for each and every one of you. We know some of you have been participating in our virtual Walk, Ride, Run for Cystic Fibrosis Challenge that concludes on October 3rd, and we appreciate your continued support, not only physically, but philanthropically. We are so close to reaching our financial goals for this challenge, and we can still use your support. However, if you're looking for other ways to support our work, we have 2 virtual fall events, and our annual fund campaign is taking place all virtually. Now, you might be wondering just how we're continuing to work during this time. We know CF doesn't stop because there's a pandemic, and we don't stop fighting for better quality of life, treatments to make your day-to-day easier, and of course, a one-time cure for everyone living with CF. So here's a little bit about what's been keeping us so busy. The CF Foundation arranged for over 10,000 home spirometers to be provided to care centers to support continued access to high-quality, comprehensive care during the COVID-19 pandemic. In May 2020, we awarded up to $5.6 million to develop a novel inhaled antibiotic to treat resistant bacterial infections in people with CF. In June 2020, we invested $14 million in effort to solve key challenges to gene delivery in CF. And in August 2020, we awarded nearly $15 million to spur infection research. This funded 33 new projects as part of our $100 million infective research initiative. And we also had to get a little creative, as I'm sure most of you have had to as well. We hosted our first ever virtual Teen Advocacy Day, a virtual volunteer leadership conference, a virtual Great Stride celebration, and over 6 virtual CF Center town halls for our local centers. Now, for a little housekeeping, please use the chat feature to give shout-outs and make productive comments. The Q&A is located on the same panel and will be monitored during the entire evening. If you have any questions that are appropriate for public forum, the appropriate member of the care team will do their best to answer them. If we, for some reason, cannot get to all of your questions, the care team will follow up with you afterwards. And as mentioned earlier, this call is being recorded. So if someone in your household was unable to attend, we'll send out a link in the coming days. So now sit back, grab a notebook, and without further ado, I want to kick us off with welcoming the wonderful Kathy Enoch. Kathy?
Hello, everyone. I want to say welcome. We're really excited to be able to still offer you this event, even though we're doing it virtually instead of in person. I do miss seeing all your faces. But I'd like to get started. So I want to thank the foundation. They've been really wonderful at helping us get this all set up and ready for you all to witness and be a part of. And really, Carrie and Marielle have been wonderful, and they're graciously hosting us, so we really appreciate that. Then we wanted to say a special thank you, of course, to those that sponsor and kind of support us through this. So although we don't get to talk to them like we did before at their tables around the event, we wanted to say a special thank you to Vertex for their continued support. And then we also wanted to mention Allergan and Alliance RX Walgreens, Gilead, AbbVie, Foundation Care, Kroger Specialty Pharmacy for all their support as well. And then just an overview of the agenda tonight, so you can kind of see what to expect for tonight. I'm really excited for all of the speakers. And I wanted to kind of thank also, our speakers that are here, Dr. Nasr, the CF Center Director, Dr. Simon, the adult program director, Dr. Thomas, one of our pediatric endocrinologists, and of course the Bauer family. But then there's also a lot of staff and faculty who are with us today. So Dr. Philbrun, our pediatric associate director, Dr. Gia, the adult program co-director, Dr. Ramirez, pediatric pulmonologist. Hannah Fan is joining us, who's actually a new pharmacist. She just joined us this month coming from Tucson, and she's actually a Michigander who's returning home. So we're really excited to integrate her into our program and get the benefit of having a pharmacist in every clinic. Rebecca Rains is one of our new roles, the parent partner role, which is really, she is on our family advisory board as well, but she is a new role that's really helped with our quality improvement in our center, and she's much more involved in that than we previously had parents involved. So it's been a wonderful experience for us, and we're excited to see where that goes in the future. Julie Lehrman and Haley Moraniak are social workers. Sharon Dagger, our RT and PFT lab supervisor. Sandy Bauma and Courtney Iwaniki, our dietitians, are joining us. Jordan Stifler, RN and interim coordinator when I was out on leave. She did a wonderful job. Ronnie Downer, of course, the adult RN, who is just astounding. She's amazing. Dawn Cruz, our research manager, and all the research team, Marisa Lynn, Jessica Carey, Morel Kalajan. And then, of course, inpatient, we had Sue Roebuck, the nurse educator, Liz Barron, the clinical nurse specialist is joining us, Diane Brown, one of the lead 12 East nurses. There's also so many staff on the adult side that I don't have all the names for, but everybody that's joining us, we thank you so much. And we're really excited to be able to share this with you. So now I'd like to turn it over to Dr. Nasr, our CF Center Director, who's our first speaker, and she's going to talk with you more about modulators.
All right. Well, good evening, and I am very excited to be hosting this with the CF Foundation. It's very important for us to continue the tradition and not to stop because of COVID. So we're very excited about tonight. Of course, face-to-face is what we really need, but till then, we can just do what we can. Before I start, I wanted to do a shout out for the foundation. They've been doing very well with us. The pharmacy position that we have. Can everybody see my screen? Yes?
Yes, we can see it.
Okay, good. The CF Foundation has been very instrumental in helping us, as was mentioned before. Half of our patients now have home spirometers, which are very important since we're doing virtual visits for patients. So that's been very helpful for us. Also, having a pharmacy on our center staff is very important, and that's through their support. And also, we're going to have pharmacy tech, especially for CF as well. So all of these are good things that's coming our way, and we really appreciate it. It all helps our people with CF to get better. So today I'm going to be talking about modulators, just to talk about the journey that we have through these last few years. And as you can see from here, is that CF is a disease that affects multitude of organs, as most of you know. It affects the lungs, it affects the sweat glands, it affects the reproductive system. The pancreas and the digestive tract is affected, with results in sometimes failure to thrive or poor weight gain, and pancreatic insufficiency, and then nasal polyps and sinus infections. And that's really just summary. There is a lot more to it than that. But I just wanted to start with this. The median survival now, or as of 2017, was about 43 years, and we expect it to get better every year. Yeah, is that your, so okay, yeah, it is showing right now. So
Okay, great.
And then I can move it?
I can move it for you if you just let me go and tell me the next one.
Okay. So this one, just different organs, how it's affecting by CF. And then next one. This is the picture I was talking about with the nasal polyps that I always talk about in clinic, and this is a nice picture for it. So I will be sharing that with my kids in the clinic. Next. So this is just to now focus on the CF gene itself, and it's called the Cystic Fibrosis Transmembrane Regulator, if you haven't heard the terminology before. And this one to your left shows you the structure of the gene. So you have 6 different pieces of it in the membrane, the cell surface of the lungs. And this is the outside of the cells, this is the inside of the cells, 2 of the ones that are in the membranes, and then you have some other one nucleotide binding domains, 2 of them, and then an R domain. And the delta F508 is in this area. Now this one shows you, to your left, shows you how it's folded into the cell surface in the lungs. So that's just to show you the structure of it. And that works as a chloride channel. Next. This one just shows you exactly where it is. This is for people that do not have CF, and people have CF. It's the same position. It's right here at the cell surface, and then you have here the cilia, or the help move the secretion from the lungs. And in people that don't have CF, it's normally open and closed according to the needs of the body to allow the chloride channel to get in and out, and the water with it as well. So you end up having very hydrated airway. In CF, it's practically the gate is closed, as I would usually say, and that does not allow the chloride to get out of the cells, and that drags the water into the cell. So you end up having very dehydrated secretions in the lungs and that in the airways, and that will lead to having infections and then having mucus plugs and other things. And that's all because the chloride channel is not working. Next. The classes of CF, the CF gene are very important because not everyone with CF have the same problem or the same gene defect. So we have some people that have class 1 mutations, which are mainly no gene is produced or very little of it is produced. And so the gene usually is produced right here in the nucleus of the cells, and then it goes out, and then it gets stronger here, and then go all the way to the cell surface. In CF, this is the first class that doesn't leave the nucleus, just stuck there. Then the most important one, or the delta F508 mutation, or class 2, it gets out, but then it gets here, got kind of entangled and misfolded. So it cannot really make it up to the cell surface. And then you have class 3, which is mainly goes all the way up, but it's not really working effectively. So the gate is not opening in the time it should be enclosed. And then class 4 is there are some abnormalities as well. And class 5 is that there is not enough CFTR. And as you can see, the degree of severity of gene problems actually goes down as you go in the numbers. So the worst is gene defect or the gene issues are in class 1, and then you go down from there. And then next slide. So this slide, and actually you can just click on it to get the rest of it. Okay. So we know that CF was identified or described back in 1936 by Dorothy Anderson, and since then the story of CF have been very exciting. So from that time, then we have some family members in the 50s that decided, you know what, we need a CF foundation. So created by families, got the CF foundation going. That followed by having care centers established for CF, and then started working on CF medications, which didn't really happen till the 90s. In 1989, that was another very important year because that's when the CF gene was identified. So that was very important for all of us. And I remember I was a fellow at the time, and it was a very exciting time. And then since then, we had a lot of excitement and a lot of people getting into CF field, and including basic scientists that work in the lab in addition to the clinical people. And then they started to work about how about gene therapy? Should we work on gene therapy? And you know the story of that, still ongoing and not really there yet. But then came the idea of having how about CFTR modulator genes that work on the gene itself and in the defect itself. And that's the story that started at that time. We've been very busy working on it, and if you can click the next slide. You can see that work started in 2000s on, and we have lots of studies going on, and then we had the Ivacaftor results came out, which is a potentiator. So works mainly on class 3 and 4. It was tried in class 2, but was not enough because it wasn't going all the way to the cell surface. So the Ivacaftor, and this is a summary slide of the modulators, and then I'll get into more specifics. So that was a very exciting time as well. So next slide. And then but the issue is, so the Ivacaftor addressed the problem in like 5% of the CF patients. We need the majority of them, which is the delta F508, homozygous and also heterozygous. So Lumicaftor, Ivacaftor came about, and it is mainly, the Lumicaftor is a corrector, so it corrects the misfolding, so it makes it not misfolded, so straight, and then goes to the cell surface, and then the Ivacaftor help potentiate the effect of it. Theoretically, that's a wonderful thing, and it should work, but we'll go over the results in a little bit. And that was in 2015, so you can see the progression really happened really quick. And then after that, next slide, we had the Tezacaftor, Ivacaftor. So the results from Lumicaftor, Ivacaftor, or the Orkambi wasn't as good as we thought it should be compared to Ivacaftor. Then you're comparing everything to Ivacaftor, kind of sometimes not fair, because Ivacaftor was amazingly good, is amazingly good. So they got a second generation corrector, which is the Tezacaftor, combine it with Ivacaftor, and we got a little better results with that. And it was less side effects as well. So next slide. So this is kind of till the end of last year when we started having other exciting information. So this one just shows you the results of the Ivacaftor. You can see the sweat chloride decreased. The average for the study was about 100 milliequivalent per liter or millimolar per liter, and it decreased to below 60. You know, the number 60 usually we use as, you know, if you're 60 or above, you have cystic fibrosis. So it's amazing that it went below that. Now, if you stop the medication, it will go up again. And then, you know, here that the FEV1 changes, and pay attention to that for a second. See, the improvement was 10%, 12%, and it was maintained through the duration of the study. When you look at how many kids got sick during the study, a lot more got sick than the people that are in the Ivacaftor. So reduced the infections for these patients as well. And then the weight, and that was a nice surprise, is that people gained weight quite a bit during the study. So all around was very exciting news, and the approval from the FDA came in real quick. So next. And it just showed you, you can just keep going. This is one of our babies. I'm assuming parents are on the line with that. Okay, next. So now to elaborate more on the delta F508 and the problem that we have with it. So, you know, it's created in the nucleus, and it then go out and then get stronger here in something called the Golgi apparatus. And then, you know, supposed to go to the cell surface to function. But then with the CF, with the delta F508, it gets here and it just, you know, folding in itself, so cannot really get it straight. It's like a driving car, and you get kind of stuck and you keep going in circles rather than going straight to where you should be. So it doesn't reach the surface, so it's kind of stuck. Next. And then not only that, it's just, okay, fine, I'm giving up, then kind of it degrades, or it's not even there anymore due to the misfolding. And then next. So we need a corrector, and the corrector is to make sure to, instead of the car going circles, we want it to go straight. So we need like a teacher to help the student driver that's driving this thing to go straight. So we have the teacher goes like, no, you just need to straighten your thing. Don't go in circles and then go straight. And that is the corrector's function. Okay, next. And that's important in that part, but you go to the cell surface and then you're not opening and closing as you should. So you need the potentiator. So you really need 2 medication rather than 1 to help with the process. Okay. Next. And this is the results of the Ivacaftor, Ivacaftor, and that's why we weren't as excited about it. I mean, it was a good tool. We used it. We gave it to a lot of patients. We still give it to patients. But you can see that the improvement in the lung function during the study was about, maybe 4%. But then as you have the open label, you can see that the start going down. So it wasn't as robust as the Ivacaftor was. So next. And this one just shows you there are two doses that were tried, and it showed even though the improvement in the lung function wasn't as great as it was in Ivacaftor, there was a reduction in the antibiotics and in the hospitalization for these patients compared to the placebo group. And next. So Tezacaftor, Ivacaftor was, like I said, the Tezacaftor was the 2nd generation of correctors, and it gave us similar effects, but it was better tolerated. So it was good to use. So we've been using it, and that's the Semdeko. So we've been using both of them according to the age of the patient. Next is okay. So early impact on the FEV1 was modest, as I said, compared to the Ivacaftor, and I always mention that to people, is that when you have the great one comes in first, then anything less, you're kind of having issues with it. So next. So that takes us to, okay, we have a good drug, which is the Ivacaftor or the Kalydeco for class 3 and 4, but we're still struggling with the Delta F508, which is the most common mutation for CF patients, actually, not only in the US, but in a lot of other countries around the world. So then the idea came in to say, well, why don't we have a triple combination? So we have 2 correctors and to help each other out kind of thing, and have a, in addition to the potentiator as well. And that's the triple combo that we got. So next slide. Right, next. So this is the gene that is misfolding, and we needed help to get it to correct the misfolding. Then next. So we did the studies. It's called Ivacaftor and Tezacaftor. So these are the 2 correctors, and then the Ivacaftor is the potentiator, and that translates into Trikafta. And that came in, and it was very important, the next slide, that it was studied at the same time with people with 1 Delta F508 mutation and people with 2 Delta F508 mutations, the homozygous group. So again, you can see the speed of how things happen here, is that you're not doing one at a time. Usually you do one at a time, but they just wanted to do everything at the same time, because really it would be that much beneficial for CF patients. Phase 2 was unbelievably good. So they went in and did that for both 1 and 2 mutations. And then next, then you can see the results here. So this is the FEV1 data, and you can see the improvement is even better than the Ivacaftor. It's like almost 15%. So it's similar or even a little better. So it was very exciting for this difficult mutation. The sweat test went down from well, about 100 to really about 60 to 50 to 60. So again, really, really exciting news. Next. And then you can look at the quality of life questionnaire that we usually use to see how patients feel. And it was much improved. It was significantly improved. So that was very exciting as well. And then the body mass index or BMI that we always talk about in clinic also significantly improved. So the weight gain was very good. And that was studied in patients 12 and above. So next slide. Most of the time when we study new drugs, we do 18 years and above because we don't want to work with younger kids because we're not sure about the side effects. But that one, because the results of the phase 2 was so exciting and the tolerance of it was so good, the FDA allowed Vertex to really start working for 12 and above. So in conclusion, that Ivacaftor, Tezacaftor, Ivacaftor combination or Trikafta provided unprecedented efficacy and favorability for the CF delta F1 or 2 mutation. And that has a potential of being beneficial for about 90% of the patients. Next. Another beautiful girls. Okay, next one. And this is shows you the effect of the modulators. This is without modulators. We know that the median survival is around 46 years of age. And then now with the Ivacaftor, you can see that it's improving. If you get to the next slide, you can see that it's even getting much better, and you know the median survival might be totally normal. And then the next slide shows you that when you have this is with the Lumicaftor, Ivacaftor. Can you imagine with the Trikafta is even better. And then the next slide would be, we don't know where we're going to be. The next slide shows you that the improvement going to continue with more availability of things. You can have me the next slide, Carrie. Yeah. So we don't know what the future will hold, but it sounds very exciting for CF. It's a good time to be in the CF field or to be involved with CF. Next. Next again. All right, so this slide shows you, and this is an important slide to show you, and you can just click till the end. Click yeah. So you can see here, as of 2016, this is the proportion of people with CF, healthy, some with decline in lung function, and some with advanced disease. And with about 52% of the adults were patients going to the adult side. And then as you can see, as we get more and more advanced, the number of adults would be a lot more than pediatrics, and the number of healthy people with CF is increasing. But keep in mind that the pink part is that there's people that will have some, decline in their lung function, some infections, and some people will still have advanced lung disease. And that's why it's very important not to get too excited and stop medications and say, we're in the Trikafta or in the, modulators and we don't need medications. We have to be very careful about that. So we have to work together with you. So next slide. Okay, next. All right, so what's the future challenges for us? So I've been using a lot of Trikafta since it came out in October. I'm using a lot of the Ivacaftor, the Lumicaftor, the Ivacaftor, and the Tezacaftor, Ivacaftor. All of them been used, but some patients might not respond as well as others. And some people might have still lung disease that's not going to go away. Infection is not going away. and lung function decline might happen. So we really have to be very careful on working with your team to adjust the medication, not to be too comfortable saying that the modulator is the end of it. And the next slide is, I'm almost done. These are just to show you that there are other companies, and you can do the next slide too. There are a lot of other companies that are working, or few of them that are working on other modulators as well, which all will translate into better efficacy of the modulator. So next. So can we achieve more by starting early? And that's really important. So you can press the next slide. It is important to start as early as you can. The more early you start, the better you will have, because before the lung damage happens, as you know, CF start in as after the babies are born. So if you start them right at birth even, then you will be better off. So that's important to keep in mind. So that will take me to the almost last slide. And that takes me to the new announcement that it came out from Vertex. There is a study going on for 6 to 11-year-old to see if we can use Trikafta on younger patients. And in September 10, it showed that there was positive results from phase 3 trials for this age group. And that will be followed by going to the FDA for approval. So we're expecting approval maybe sometimes next year. And then I will end with the last slide. And this is one of my babies that I took care of when she was very little, and she was very unique and very cute too. And now she's 21 and she is going to the adult side very soon. So it's exciting to see her grow and get better. So thank you very much.